Bismillah ar-Rahman ar-Rahim. Today we are going to discuss a very important subject, which is infective endocarditis. It's not an uncommon disease that we usually find in our daily practice. We'll start with simple introduction. Definition of endocarditis is inflammation of the endocardial lining of the heart. We should know that the most common portals of entry are oral cavity, where commensal flora and bacteria exist, gastrointestinal tract, and skin. Also, healthcare-associated invasive procedures are a very common way to lead to infective endocarditis. Unprotected vascular punctures, especially in people who inject drugs and addicts. As we say, prevention is better than cure. So the most important and very important point that has been emphasized in these and the previous guidelines of infective endocarditis is prevention. So we should know that we have different categories. Also, first we have population and procedures. In population, we have high risk population, intermediate risk, and low risk. And regarding procedures, we also have dental procedures, non-dental procedures, and cardiac or vascular procedures. We'll start with high-risk individuals. These individuals, once you have one of these people who are at high risk, you should always suspect infective endocarditis, engaging in other signs and symptoms and the clinical presentation of the patient. High-risk individuals comprise of people with a history of previous infective endocarditis, patients with surgical transcatheter implanted prosthetic valves, cardiac valve repair material, like in case of ASD, VSD, left atrial appendage closure devices, vascular graft, IVC filters, and so on, usually within the first 6 months of these procedures. Also ventricular assist devices and untreated cyanotic congenital heart diseases. Patients who are treated with palliative shunts and conduits and prostheses. All these patients with high-risk cardiac disease and invasive or prosthetic or foreign body materials within the heart are categorized as high-risk individuals. Intermediate risk are patients with rheumatic heart diseases, non-rheumatic degenerative valve diseases, congenital valve abnormalities, as in case of bicuspid aortic valve, and cardiac implantable electronic devices, which is a separate category in infective endocarditis, and patients with hypertrophic cardiomyopathy. The guidelines regarding prophylaxis of infective endocarditis, it stresses on the infective endocarditis prevention in patients in high-risk procedures. Usually, the most important procedure that we have to take precautions prior to is high-risk dental procedures like dental extraction, oral surgical procedures, and procedures requiring manipulation of the gingival area and the periapical area. The recent addition to these guidelines that wasn't present in the previous guidelines in 2015, in the guidelines of 2023, systemic antibiotic prophylaxis may be considered for high-risk patients undergoing an invasive diagnostic or therapeutic procedure of respiratory, gastrointestinal, gastrourinary tract, skin, or musculoskeletal system. Any invasive diagnostic or therapeutic investigation or procedure of other systems other than the dental procedures. It's a class 2B to give a prophylactic antibiotic in high-risk patients. But we usually, according to our daily practice, also intermediate risk patients could also have antibiotic prophylaxis prior to these procedures. Since it's in the previous guidelines, it was a class 3 to give prophylactic antibiotics to any other procedure rather than the dental procedures. But it was the consensus to give not to give antibiotic prophylaxis in a high-risk patient wasn't acceptable. So it was upgraded in these guidelines to Class 2B to give high-risk patients and invasive diagnostic or therapeutic procedures prophylactic antibiotics. Also, infective endocarditis prevention in patients at increased risk of infective endocarditis and undergoing orodental procedures. The general prevention measures are recommended in individuals at high and intermediate risk of infective endocarditis. General prevention measures apply to both high risk and intermediate risk population. Antibiotic prophylaxis is recommended in patients with, as we said before, in high-risk patients, previous infective endocarditis, surgically implanted prosthetic valves, transcatheter implanted valve prosthesis, and untreated cyanotic congenital heart disease, as we said before. Antibiotic prophylaxis should be considered in transcatheter mitral and tricuspid valve repair is Class 2A recommendation. Infective endocarditis prevention in cardiac procedures. Preoperative screening of nasal carriage of Staph aureus is recommended before elective cardiac surgery or transcatheter valve implantation to treat carriers. So screening of the nasal cavity for Staph aureus before elective cardiac surgery. Of course, if it's at urgent or emergent cardiac surgery, we don't have to do this step. Perioperative antibiotic prophylaxis is recommended before placement of cardiac implantable electronic devices and in patients undergoing surgical or transcatheter implantation of a prosthetic valve, intravascular prosthesis, or any other cardiac procedures, and antibiotic prophylaxis covering the common skin flora, including Enterococcus and Staph aureus, should be considered before TAVI and other transcatheter valve procedures. So these all are recommendations regarding cardiac procedures specifically. It's a Class 3 recommendation that systemic skin or nasal decolonization without screening of Staph aureus is not recommended. I don't know if this is even applicable. So the recommendation and recommended prophylaxis for high-risk dental procedures in high-risk patients, so it's high-risk dental procedures in high-risk patients, we should give prophylactic antibiotics prior to the procedure. It's a single dose of antibiotic, 30 to 60 minutes before the procedure, 30 if you're going IV antibiotic and 60 if going with oral antibiotic. In case of non-allergy to penicillin, amoxicillin or ampicillin, cefazolin or ceftriaxone. If allergic to penicillin, cefalexin, azithromycin, clarithromycin, doxycycline, and so on. So you can back to this table as a reference. We have also general prevention measures that we said for high risk and intermediate risk patients. There are general measures regarding the hygiene and antibiotic use and so on. These measures should apply to general population, particularly and reinforced in high-risk patients. They should be encouraged to maintain twice daily tooth cleaning, mouth hygiene and skin hygiene, disinfection of wounds, curative antibiotics of any focus of bacterial infection, no self-medications and antibiotics or abuse of antibiotics, strict infection control measures for any at-risk procedure, discouragement of piercing and tattooing, limitation of infusion catheters and invasive procedures when possible. Strict adherence to care bundle for central and peripheral cannulas should be performed. This was the part we spoke about prevention. Now we will speak about diagnosis. So to diagnose a patient with infective endocarditis, you should first divide into cardiac risk factors and non-cardiac risk factors. Cardiac risk factors are previous infective endocarditis, valvular heart disease, prosthetic heart valve, central or arterial catheters, transvenous cardiac implantable electronic device, and congenital heart disease. Non-cardiac risk factors are central venous catheters, people who inject drugs, immunocompromised patients, recent dental or surgical procedure, and recent hospitalization and hemodialysis. So the diagnosis of infective endocarditis is a multidisciplinary team process, and of course focusing on the cardiologist. And also you have a stepwise approach, or very different modalities and steps to reach the diagnosis of infective endocarditis. There is no specific clinical feature or no specific lab test that can confirm this diagnosis immediately, but there are a very collection of signs, symptoms, history taking, risk factors, and also other imaging modalities. So we'll start with clinical features. Fever, of course, as it's an infection, fever and positive blood cultures in the absence of alternative focus of infection, especially in patients with one or more risk factors that we mentioned before. So this fever and positive blood culture should raise suspicion in patients with risk factors to infective endocarditis. Also, another clinical presentation that the patient may present with is fever and embolic phenomena. It's up to 25% of patients have embolic complications at the time of diagnosis. So the patient may present with fever and stroke, for example, or embolic focus resulting in pneumonia or a pulmonary infarction. So we should keep this point in mind. Other presentations, the patient with infective endocarditis may come with acute, subacute manifestations and complications as the first presentation, and atypical presentations. Acute presentation is more common in patients infected with Staph aureus, as it's a virulent organism. Subacute, most probably with streptococcal infection. Complications, as we said, it may be the first presentation, complication as stroke, pneumonia, or other septic or embolic manifestations. And atypical presentation, as the patient may come afebrile, especially in old age and immunocompromised patients. And other clinical features, the patient may come with a new murmur, new cardiac manifestations. This also should raise suspicion to infective endocarditis, involving the other circumstances with the patient. These are some immunological manifestations that are associated with infective endocarditis, and most commonly in the subacute phase or subacute infective endocarditis. The immunological presentation come as Osler's nodules. These are round, tender nodules that appear on the palms and the soles of the hand. They usually last for a few days and then disappear. Rust spots, it's hemorrhagic spots in the retina, resulting from also embolic events to the retina. Glomerulonephritis, it's a very common association with infective endocarditis, especially in a young age group. So the patient may first come with glomerulonephritis or other renal manifestations. We have also a positive rheumatoid factor. Regarding vascular manifestations, the patient may come with Janeway lesions. These are also skin lesions, but they are irregular and non-tender. They present on the palms and soles, and the eminence and hypothenar and hypothenar eminences of the hand. Mycotic aneurysms, which occur in the brain, splinter hemorrhage and the nail bit, and major arterial embolism. Regarding the lab test, there is no, as we said before, there is no specific test to confirm or deny the diagnosis of infective endocarditis. But we do some tests that may lead to help in directing our investigations and diagnosis towards infective endocarditis. So we'll start with CBC and white blood count. CRP, of course, is very important. at the beginning of the investigations and during regular follow-up. Procalcitonin to exclude and or confirm the presence of sepsis. Other end organ dysfunction labs like BNP, bilirubin, kidney function, and according to the presentation the patient comes with. As we said, it's used for risk stratification and follow-up mainly. The other important investigation is microbiological tests. Since Staph aureus is the most common organism to cause infective endocarditis with 31%, oral streptococci comes second, and coagulase negative staphylococci. So we have three categories in the microbiological testings, or three results that we may face. The first one is blood culture positive infective endocarditis, a blood culture that is withdrawn with specific criteria. We have to take at the beginning of investigation and before starting any antibiotic treatment. We should withdraw 3 sets of blood from 3 different sites at 30-minute intervals, 10 millimeter each on aerobic and anaerobic medium. Of course, starting the antibiotics is starting early antibiotic treatment for infective endocarditis is a very important step, but sometimes or usually blood cultures take over 5 days to appear. So during these 5 days, we should start, as we will discuss later on, we will start empirical antibiotic treatment, but also there is a measurement or a step that we can do in cooperation with the clinical pathologist to emphasize that this patient is suspected for infective endocarditis and this blood culture is to confirm or decline the diagnosis of infective endocarditis. So the clinical pathologist can help us in identifying in the first 24 hours the type of the type of the microorganism according to the gram staining. We don't have to identify a specific organism, but at least we direct our treatment regarding not an overall group, but regarding specific group. It will reduce the fallacies and the unnecessary antibiotic treatment. Also, another option is that we may have blood culture negative, which also a different entity in infective endocarditis we will discuss later. The blood culture doesn't show any microorganism or pathological examination of after extraction of the septic emboli or a destructed valve after cardiac valve surgery. This is pathological examination for the specific, for tissue examination for the specific microorganism. That will confirm definitely the diagnosis. Blood culture negative infective endocarditis. It may occur due to 3 causes. Previous antibiotic administration, the patient already started antibiotics before the withdrawing of the blood culture samples. So it will give negative culture. Sometimes we can overcome this problem by, if the patient started the antibiotics for short duration, like 2 days or so, we can stop the antibiotics and repeat the culture later. But of course, if the patient is vitally stable and he is not unstable or the case is not risky, so in this case we can stop the antibiotics and repeat the blood culture again. Another reason that fungal or fastidious bacteria, notably obligatory intracellular bacteria that can't appear in the blood cultures. So in this case, we use other modalities to identify the microorganism, like isolation of these microorganisms requires culturing on specialized media according to the suspected microorganism, and serological testing and specific PCR. and non-bacterial endocarditis. This is a endocarditis case, but not due to infection with bacteria. It should be systemically be considered if all assays are negative. So we suspect that the patient may be due to immune disease. So we undergo assays for anti-nuclear antibodies as well as antiphospholipid syndrome and other autoimmune labs. Also anti-port antibodies in patients with porcine biprosthetic valves. Also, I have to note that in some places, according to the most common organisms or the percentage of organisms that they find, they sometimes do serological testing as a routine for zoonotic infections, which are not uncommon in Egypt. So you should adjust your labs and your antibiotics and other all the other steps that you do according to your local circumstances. Now we will discuss imaging. We'll start with echo, which is the cornerstone of diagnosis of infective endocarditis. CT and MRI and nuclear imaging. So echo also comprises of transthoracic echo and transesophageal echo. Transthoracic had low sensitivity but good specificity as compared with transesophageal echo. So if we find in transthoracic echo, if we definitely find masses or suspected infective endocarditis, it's a very good sign and it confirms the diagnosis. Of course, we will do further investigations, but it has good specificity. But if you couldn't find masses or confirmed diagnosis of infective endocarditis using transthoracic echo, you still can't exclude the diagnosis of infective endocarditis, and you should go further with other modalities. We use, of course, we use transthoracic echo and echo in general to identify the vegetation's characteristics and size, perivalvular complications, and we use it in follow-up reports. Transesophageal echo in patients with an inconclusive transthoracic echo. If you have negative transthoracic or can't confirm the diagnosis, a patient with negative transthoracic and high suspicion of infective endocarditis, patient with positive transthoracic echo, in order to document local complications. Also, in prosthetic heart valve or in intracardiac devices, you should do transesophageal echo. Transesophageal echo, of course, it's very liable for confirming the diagnosis of infective endocarditis, but it may miss vegetations in some cases, like in very early stage of infection, very small vegetations less than 3 millimeter, pre-existing severe valvular lesions like myxomatous mitral valve, calcified aortic stenosis, and prosthetic valve. Echocardiography, transthoracic or transesophageal, should be repeated 5 to 7 days. First, after initial normal or inconclusive echocardiography, if the suspicion of infective endocarditis remains high. In patients with diagnosed infective endocarditis at high risk of complications, if the patient is infected with Staph aureus bacteremia, and patient with prosthetic valve and negative initial transesophageal, you should repeat the transesophageal or transthoracic, even if it's negative. At the beginning or at the initial diagnosis, you should repeat it 5 to 7 days in these cases. This is a picture of mitral valve vegetation, very obvious. This is transthoracic, and this is transesophageal echo. Transesophageal echo of mitral valve with large vegetations causing stuck anterior mechanical valve occluder. This is mechanical valve with infective endocarditis, diagnosed with transesophageal echo. This is also posterior periprosthetic aortic abscess. Transesophageal echo is a very good modality in diagnosing aortic abscesses or abscesses in general. and we will discuss in details. These are the recommendations of using echocardiography in diagnosis. We will repeat the notes that we said before, but in the form of arranged guidelines. So diagnosis of with the transthoracic echo is recommended as the first-line imaging modality in suspected infective endocarditis. Also, transesophageal echo is recommended in all patients with clinical suspicion of infective endocarditis, and negative or non-diagnostic transthoracic echo when prosthetic valve, high heart valve, or intracardiac device is present. Even in the cases with positive transthoracic echo, except in patients with isolated right side native valve endocarditis with good quality transthoracic echo examination and unequivocal echocardiographic findings. So if we are suspecting right side infective endocarditis and transthoracic echo was clearly positive and unequivocal, this is the only case that we can't or we shouldn't do transesophageal echo. As the right side of the heart is more anterior and best to visualize better with transthoracic and not transesophageal echo. Repeating transthoracic or transesophageal echo within 5 to 7 days in the case of initially negative examination or inconclusive examination. Performing an echocardiography should be considered in Staph aureus, Enterococcus faecalis, and some Streptococcus species bacteremia. This was diagnosis. Now we will talk about follow-up under medical therapy. Repeating transthoracic and transesophageal echo is recommended as soon as new complication of infective endocarditis is suspected, like new murmur, embolism, persistent fever, heart failure, or abscess and AV block. So if any other cardiac complication appeared, you should immediately do repeat transthoracic and transesophageal echo and don't wait for a certain period. Also, repeat transthoracic and transesophageal echo should be considered in uncomplicated infective endocarditis to detect new silent complications. The timing to repeat transthoracic and transesophageal echo depends on the initial finding, type of microorganism, and initial response to therapy. So sometimes there are silent complications that we can't give us, that they can't give any alarming signs. So you should repeat transthoracic and transesophageal echo regularly according to the organism and the general condition of the patient. Transesophageal echo is recommended when patient is stable before switching from intravenous to oral antibiotic therapy. This is a very important point that will come later on. Intraoperative echocardiography is recommended in all cases requiring surgery. Following completion of therapy, transthoracic and transesophageal echo are recommended at completion of antibiotic therapy for evaluation of cardiac and valve morphology and function in patients with infective endocarditis who didn't undergo heart valve surgery. Next, we will talk about cardiac CT. Cardiac CT also plays a very important role in infective endocarditis patients. It's used for diagnosis of infective endocarditis, cardiac complications. It's very important to diagnose the cardiac complications that are commonly accompanied with infective endocarditis. So cardiac CT is more accurate than transesophageal echo for diagnosing perivalvular and periprosthetic complications of infective endocarditis, and is recommended in both native valve and prosthetic valve if transesophageal echo is not conclusive or not feasible. As we said, we will perform transesophageal echo. It may or may not show us the perivalvular complications. We of course we should use it in also in prosthetic valve, but cardiac CT is more accurate and more superior in this point. Detection of distant lesions and sources of bacteremia. Performing a whole body CT and brain CT are very useful for assessing infective endocarditis, systemic complications, including septic emboli and mycotic arterial aneurysms. We will diagnose cardiac complications and extracardiac or distant lesions and distant sources of bacteremia. Preoperative assessment of coronary artery disease before cardiac surgery in patients with infective endocarditis. If the patient is going definitely to undergo cardiac surgery, he should perform cardiac CT to assess the coronary artery disease, the presence of coronary artery disease. It's also better than coronary angiography, especially in the case of aortic valve infective endocarditis, to avoid the manipulation and distal embolization, embolic to iatrogenically lead to embolic manifestation in the coronary or systemic embolization. Also, it's used to provide alternative diagnosis in patients in infective endocarditis is ruled out, and alternative diagnosis can be reached by whole body CT. Other modalities also can be used, like PET scan. MRI is not used to diagnose infective endocarditis per se, or to diagnose the cardiac complications of infective endocarditis, but it should be used to diagnose neurological infective endocarditis related complications like brain MRI. Also in diagnosis of spine lesions, MRI is the diagnostic modality of choice in spondylodiscitis and vertebral osteomyelitis, which is also common association with infective endocarditis. It could be the cause or as a complication of infective endocarditis. So we should keep it in mind in patients complaining of back pain or other vertebral lesions. Nuclear imaging, PET-CT and SPECT. It's most commonly used in prosthetic valve and cardiac implanted electronic devices patients. But it should be used after 3 months of the procedure, since before that we still have like inflammatory or high uptake of the material, so it will give false positive results. It's used in diagnosis of infective endocarditis and cardiac complications. They are recommended in suspected prosthetic valve in case of inconclusive echocardiography, detection of distant lesions and sources of bacteremia, and monitoring response to antimicrobial treatment. But I think this point is not very feasible as it has high cost, and other modalities can be used to provide the alternative diagnosis. In patients with established infective endocarditis and indication for surgery, but who can't be operated on due to unacceptable high risk and remain with long-term suppressive antibiotic treatment. PET-CT is less suited to detect cerebral septic emboli and mycotic aneurysm of intracerebral arteries due to high physiological uptake of 18-fluorodeoxyglucose in the brain. So we don't count any activity in the brain in this. The recommendations regarding CT and nuclear imaging and MRI infective endocarditis. Cardiac CT angiography is recommended in patients with possible native valve endocarditis to detect valvular lesions and confirm the diagnosis of infective endocarditis. Also, it's recommended in possible prosthetic valve alongside with PET-CT to detect valvular lesions and confirm the diagnosis of infective endocarditis. Cardiac CT is recommended in native valve and prosthetic valve to diagnose paravalvular or periprosthetic complications if echocardiography is inconclusive. Brain and whole body imaging are recommended in symptomatic patients according to symptoms, with native valve and prosthetic valve to detect peripheral lesions or add minor diagnostic criteria. So as we said, CT is used to confirm the diagnosis, and we add PET-CT in case of prosthetic valve and to detect complications, diagnose paravalvular or periprosthetic complications in native and prosthetic valve patients. PET-CT may be considered in possible CIED-related infective endocarditis to confirm the diagnosis, and brain and whole body imaging CT in native and prosthetic valve may be considered for screening of peripheral lesions in patients with asymptomatic patients. This is a picture of fluorodeoxyglucose PET-CT test in patients with suspected implantable cardioverter defibrillator pocket. So the white arrow points to the pocket, and the black arrow points to the intravascular or intracardiac lead. It shows high activity at the pocket site. So it shows a high probability of CIED-related infective endocarditis or infected site of the pocket. This is a table of anatomical definition of infective endocarditis lesions and complications, like vegetations, abscess, pseudoaneurysm, perforation, fistula, valve aneurysm, and dehiscence of prosthetic valve, which are and how to see them or how to detect them in the echo. So after performing all these investigations and the lab tests and the blood cultures with the history of the patient and the risk factors and all the data that we collected about the patient that rose suspicion to diagnosis of infective endocarditis. The modified 2023 Duke's criteria of diagnosing infective endocarditis. We have major criteria and minor criteria. The major criteria comprise of blood cultures and imaging, positive imaging of infective endocarditis. So blood culture positive for infective endocarditis may be in typical microorganisms consistent with infective endocarditis from two separate blood cultures. These typical microorganisms like oral streptococci, Streptococcus galoleticus, Hasig group, and Staph aureus and Enterococcus faecalis. So if you find any of these organisms in a blood culture positive in a patient with suspected infective endocarditis, it gives a 0.2 major criteria. In case of microorganisms consistent with infective endocarditis, not definitely causing infective endocarditis, but consistent with the diagnosis, from continuously positive blood cultures, from two or more positive blood cultures of blood samples withdrawn more than 12 hours apart, or in all of three or majority of more than 4 separate cultures of blood, with the first and the last sample withdrawn with more than 1 hour apart. This applies only in microorganisms consistent with infective endocarditis. But as we said, if typical microorganism in 2 separate blood cultures, this is a major criteria. We can have single blood culture for Coxiella burnetii or phase 1 IgG antibody titer, more than 1 to 800. The other major criteria in case of imaging positive of infective endocarditis is to find valvular, perivalvular, periprosthetic, and foreign material anatomic and metabolic lesions characteristic for infective endocarditis detected by any of the following imaging techniques that we discussed: echocardiography, whether transthoracic or transesophageal, cardiac CT, PET-CT, and SPECT-CT. So positive blood culture and positive imaging of valvular lesions in any modality gives major criteria. The minor criteria, we have 5 points. The first is predisposing condition, like predisposing heart condition at high or intermediate risk of infective endocarditis patient, or in patients with people who injected drugs. Any of these give one minor criteria. Fever defined as temperature more than 38 degrees, embolic vascular dissemination, including those asymptomatic detected by imaging only. So if screening, as we said, in asymptomatic patients revealed asymptomatic embolic complications, we will give one minor criterion. For example, major systemic and pulmonary embolic infarcts or abscesses, hematogenous osteoarticular septic complications like spondylodiscitis is the most frequently osteoarticular infective complication in patients with infective endocarditis. So it shouldn't be underestimated. Mycotic aneurysms, intracranial ischemic or hemorrhagic lesions, conjunctival hemorrhages, or Janeway lesions that we said before. Also, immunological phenomena, right, like glomerulonephritis, Osler's nodules, and Ross spots, and rheumatoid factor. The last one is microbiological evidence, positive blood culture, in case of positive blood culture, but it doesn't meet the major criteria that we said before. Also, serological evidence of active infection with organism consistent with infective endocarditis. So the classification of infective endocarditis and diagnosing this disease according to the data that we collected and applying the modified Duke's criteria, major and minor criteria, we can get definite diagnosis of infective endocarditis if we have two major criteria, or one major criteria and at least 3 minor criteria, or 5 minor criteria. Possible diagnosis if we have one major criteria and 1 or 2 minor criteria, or 4 minor criteria. But in practice, we treat possible infective endocarditis as if it's a definite infective endocarditis, as this is a very risky or high risk disease with very bad complications and very dangerous complications. So we shouldn't leave it to chance to definitely diagnose this disease and start the appropriate treatment. Only rejected diagnosis if it doesn't meet criteria or definite or possible at admission, or with or without alternative diagnosis. This is an algorithm and the guidelines to follow in the diagnosing and the investigations to do in case of suspected infective endocarditis. The last point is predictors of poor outcome in patients with infective endocarditis. We have patient characteristics, clinical complications, microorganisms, and echocardiographic findings. Patient characteristics that give poor predictors of poor outcome in this patient, like a patient with older age, prosthetic valve, diabetes, and other comorbidities like frailty, immunosuppression, renal or pulmonary diseases. Clinical complications of infective endocarditis like heart failure, renal failure, more than moderate area of ischemic stroke, brain hemorrhage, and septic shock. Microorganisms with poor outcome, Staphylococcus aureus, fungi, and non-Hasek gram-negative bacilli. Last point is echocardiographic finding, like periannular complications, severe left-sided valve regurgitation, low LV ejection fraction, pulmonary hypertension, large vegetation, severe prosthetic valve dysfunction, premature mitral valve closure, and other signs of elevated diastolic pressure. Thank you. See you next lecture.